Thanks very much. Thank you for asking me to speak. I was very grateful because Ian doesn't normally let me speak in the departmental meeting, let alone in front of a room this size. Nothing new under the sun. Adhesions were described a long time ago. Post-mortem studies from 1836 first described adhesions, and laparotomy, the first laparotomy for adhesional small bowel obstruction was written up in 1883. The way Ian tells the story, a patient came in 6 weeks after gynecological surgery, after removal of an ovary, and the gynae reg was straight on the phone saying it was nothing to do with them. Adhesions, even in 1925, were a common cause of small bowel obstruction in UK hospitals. Just over 10% of cases of small bowel obstruction in a survey in 1925 being put down to adhesions, and that's only become more common as abdominal surgery has become more common itself. The scale of the problem was addressed, probably most referenced, the SCAR study using the Scottish database, and showed that just over 5% of patients have a readmission relating to adhesions within 10 years of a laparotomy. We know they form a large number of emergency surgical admissions and around 20% of emergency laparotomies in the UK. And Emma, who's coming after me, will tell you that they're associated with high mortality. And this mortality is variable across different hospitals, and that, I guess, makes us all think about what we can do differently. The immediate steps are the kind of things Ian's promoted with the CRISP algorithm: fluid resuscitation, insertion of an NG tube, a catheter and analgesia, attention to other medical problems, often anticoagulation and diabetes, in what's frequently an old group with comorbidities. Some thought given to where these patients should be initially nursed, perhaps in a high dependency unit if need be, and early aggressive senior assessment. Because there's some decisions to be made early on. Is there evidence of strangulation and ischemia, so the patient needs to go to theatre? Do we know what the cause of obstruction is? Because that's going to determine how we manage things. And if it does prove to be adhesions, how long can we wait to operate? How long can we manage this patient conservatively? There's a lot of causes, and I'm going to be talking about adhesions, and actually the diagnosis isn't early, so one of the things we do is get an early CT. Because actually, if it's mechanical and non-adhesive, if there's an obstructing cancer, if there's a hernia that we haven't picked up clinically, an internal hernia, if there's gallstone ileus or a volvulus, the patient isn't going to benefit from a trial of conservative management. They need an operation. Similarly, if we're sure that this is functional, if there's just evidence of ileus, opiate-related or diabetes, or as is often the case, a patient on ITU with a form of ileus or pseudo-obstruction related to their critical illness, we're not going to operate at all. And so the rest of the talk is going to be talking about adhesional small bowel obstruction. I've said there's a role of CT to make the diagnosis. There's also a role for CT, even to help with making that perhaps early decision as to whether this patient needs an emergency laparotomy because they've got ischemic or strangulated bowel. Because actually, we don't seem to be great at making that judgment clinically. The signs, the judgment isn't great, and you can see there in this American study, even very senior surgeons' judgment wasn't great. I've had an interesting week. We've had some prize winners, scholarship winners from Africa over visiting the hospital at Salford and then joining us the rest of the Manchester Surgical Week. And I hope they've enjoyed it, and they certainly fed back that they enjoyed the visit to the hospital. We had the group of first prize winners here. I'm told the group of second prize winners have enjoyed their week in London just as much. But as what we've enjoyed is actually learning how they manage all of these cases across massive populations with limited resource, really mainly with their clinical judgment, because in our hands, our judgment isn't perhaps as good as we think. So we get the CT, and it gives us diagnosis of cause. If we haven't picked up on strangulation or bowel ischemia or closed loop obstruction clinically, it's very good at doing it. And so look, this is a CT that demonstrates actually quite high-grade small bowel obstruction, just the suggestion of some swirling vessels, the suggestion that this is going to be wrapped around a band adhesion. And it was. There was a nice band adhesion that was divided, and things went well, and an early CT meant there was no delay getting to surgery. After the CT, we are a bit better about predicting the risk of strangulation and ischemia. There's a nice model from the World Journal of Surgery that got a little bit of press that shows if you use these 6 variables, we become quite good that if getting well over 80-90% chance of spotting patients who really need early surgery once we incorporate the CT. The ones that we don't will deteriorate and be picked up at that point. The ones who have now diagnosed adhesional obstruction, who aren't needing to rush to theatre, we will start to manage conservatively. And the question is, how long can we do that for? And is there any rush to get this decision right about how long we can wait? And I'm going to present a sequence of studies over really the past 20 years, all coming to fairly similar conclusions, which is that something in the order of between 2/3 and 80% of patients with proven small bowel obstruction will settle. So the study from New Zealand, 85 out of 123, and most will settle in a couple of days. Those that are going to settle within 3 days. Two big papers, similar results, 65-75% of cases will resolve without surgery, higher grade obstruction, less likely to settle, resolution within 72 hours if it is going to happen. There's the Bologna guidelines that a lot of us have looked at. Again, same message. It's safe to manage patients conservatively for up to 72 hours. If they haven't settled after 72 hours, surgery is recommended. Patients treated non-operatively, perhaps unsurprisingly, have a shorter stay, but they do come back. Those that don't get operated on come back sooner than those that do, and actually the risk of future surgery unchanged. And there's a model out there to predict the need for a laparotomy that can potentially be valuable. But within that, although we know it's safe to wait for potentially 3-4 days before operating if someone isn't settling, there's another little problem in the data. And there's this question about never let the sun set on a small bowel obstruction. How many sunsets can you wait? Because actually, although patients will settle for up to 3-4 days, those within that group who don't settle and come to surgery do worse the longer they're sat on before going to surgery. And so that then raises the question, can we do better other than just waiting for judging the ones that aren't going to settle? And this study very nicely demonstrated across a very big group, 25% of those that went to surgery had a resection. They stayed for about 8.5 days, but they showed these important messages. Waiting longer in the group that went to surgery was associated with increased mortality. That delayed management was equally associated with a long stay. They said observed for no more than 5 days. But if you look, the numbers, the rate of mortality and complication was going up way before then. A more recent paper again shows earlier operation in those patients who need it is associated with a survival benefit, reduced mortality, shorter hospital stay, fewer complications. And interestingly, it's not because of ischemic bowel. There's no difference in the number of patients having a bowel resection. It's because, unsurprisingly, in this morbid group, a trial of starvation before laparotomy isn't beneficial. If we could identify who needs an operation earlier, we'd do better. And this chart's so similar. As you wait longer, problems go up. And so the conclusion from all of these studies is that most cases of adhesional small bowel obstruction will settle. Those that won't need surgery, and the earlier the better, because delayed surgery is bad. And so the sooner we could make that decision, the better, even though we know many will settle if left. And that's why there's a role for an early contrast study, because if there's contrast in the colon, it's going to resolve most of the time. And so there's a couple of papers over the last 10 years that have got a lot of press that showed early use of gastrograph in contrast helped make that decision earlier. It showed that this paper showed conservative treatment was successful in over 80% of patients, and actually the hospital stay was shorter in the group who were given early gastrograph in than the group who were managed conservatively and waited on with clinical judgment. All the patients in whom contrast reached the colon tolerated early oral diet and went home. And similarly, a second paper showing very much similar message in the group that were given early gastrograph in a contrast study, time to resolution of obstruction, hospital stay was better. They interestingly showed a reduced operative rate. The numbers were relatively small, so I'm not sure how much we can make of that. There's been a couple of meta-analyses of this data showing that contrast appearing in the colon within 24 hours does predict resolution, and it's sensitive and specific, and it does lead to a reduced length of stay. So on the back of that, on one of Ian's earlier instructions, I helped contribute to the writing of the ASGBI guidelines, and we produced a flowchart that is intervention happy and does use a lot of radiology. So if a patient comes in with the diagnosis of small bowel obstruction, if you clinically diagnose a hernia or a bowel ischemia, operate. If that isn't absolutely the case, so you're not rushing the patient to theatre, a CT at that point. And if it shows bowel ischemia or a cancer causing a blockage, they're going to need an operation. Only that group who've got adhesional small bowel obstruction are where we have said a trial of conservative management is reasonable for 48 hours, but at that point, a water-soluble contrast study, and if the contrast isn't reaching the colon, to operation. At that point, it's safe to wait for a length of stay of another 3 to 5 days, and the vast majority would seem to resolve at that point. Although there is always the potential, because nothing's perfect, that even that group may not settle. One of the things Ian's talked about is possibly whether should be even speeding that up. Should we be waiting 48 hours, or should it be the next morning after the CT scan that the patient has the contrast study? Because could we get people home even sooner? If the morning after diagnosis they were going for a contrast study and the contrast got through, could they have lunch and then go home? As I've said, and I'm promoting the college itself, and actually with the armament of having involved commissioners, has produced guidelines that contains that same flow chart advocating an early CT and early contrast study. I'm very grateful to Claire Hall, who's done a lot of the work, one of our trainees who's done a lot of the work gathering the literature review, and we came across another couple of things that I thought were worthy of bringing to light, because one of the questions is surgery just going to happen again after laparotomy and adhesiolisis? And the evidence is actually no, there's fewer readmissions after adhesiolisis for small bowel obstruction. And then some of the other things we talk about, what's the role of laparoscopy? Well, in experienced hands, people who feel comfortable doing it, there probably is reduced length of stay. But you've got to be confident getting your ports in with dilated bowel, and you've got to be confident you can handle that dilated bowel safely. I guess it's particularly suited to patients where you're clear there's a band adhesion and you think it's going to be relatively technically straightforward aside from handling the bowel. There's no evidence for putting in anti-adhesion products to try and reduce the rate of reformation of adhesion small bowel obstruction. And as I'm sure Emma's going to come on to, by definition, surgery for small bowel obstruction is associated for more than 10% mortality, and so senior anaesthetic and a surgical team are required. Too high a price. I know we probably have to be literal with the talk. Too long a wait I've addressed. Too high a price, possibly difficult. There's a number of models of how much adhesional small bowel obstruction costs. The SCAR group have been quite active in that, so they found that in Scotland, which is going to be key to everything we do, 2% of hospital costs in a paper from 1999 seem to be associated with adhesional small bowel obstruction. The SCAR study looked at their data and found a cost of 570 million for every year's laparotomies in terms of readmissions and treatment for adhesions. There's an American study that suggests a 1.3 billion total cost of adhesion surgery, and a Finnish model as well. The truth is all of these are models. It's hard to know how reliably to look at the numbers. In an ideal world, it would be nice to model the additional cost of radiology and show whether that would pay its weight in terms of improved outcomes, reduced hospital stay and finances. And I guess that's something that's troubled me, but actually watching the news over the past couple of weeks, I've learned that you actually don't need to be so careful. It's often sufficient to merely look sincere, place your hands forward to look honest, and assure everyone that implementation of this pathway will pay for itself over the course of the next Parliament. I'd like to thank everyone for letting me speak today, and I'm open to questions.